Assalamualaikum. Bismillahirrahmanirrahim. Thank you very much to Mastro, not the executive committee, to the Mastro present attendees, because I'm part of the committee. Thank you very much, Prof. Pignol, for restricting me in time. I'm very badly sandwiched because speakers before me were great and the speaker after me is good. I'll try to survive, but I'm already sweating. So with the time interest, actually, I would move a little bit faster. So my talk, and I have to thank a few people, Dr. Binaz Yasser, because she presented the SBRT already, so I don't have to go into that detail. And Professor Ben, I don't know if he's in the hall or not, but he will be talking about the brachytherapy. So I'm out of that as well. And then another doctor will present the hormonal treatment. So I don't have to present all those. So my topic is limited. I try to focus, and I would like to have your focus towards the topic, because I'll talk only very few but important points. So this is a general slide which you have seen maybe 100 times, that, risk categories. When prostate cancer is localized, we have low risk, medium risk, and high risk. I don't go into details. Then when the cancer go out of prostate, can be regional node positive disease or can be metastatic. And metastatic can be solitary met, oligomet, low burden or high burden. So the reason I'm setting the pitch that I would only pick some of it, and I'll explain that what are the differences which come into the practice in very recently. So with this slide, I assume everybody understand what I'm saying. Raise hand if you don't understand. So if you understand, you're okay. Okay, everybody understand. Now we move to the next point. So I'll talk about the low risk category and low tier or favorable intermediate risk category. In my experience, I learned that these two categories work very well, very similar. There are treatment options for them. Active surveillance is one of them. But actually what we do in practice, we do watchful waiting. Most of the patients don't have regular biopsy, and they actually end up having watchful waiting. One experience, I did a Canadian study, bias, and in bias study, when we follow them, I learned that active surveillance is actually deferred treatment. It's not that you get out of treatment. Many times patients become nervous when their PSA go up or their Gleason score progress, and eventually we treat them. So all we do is we defer. Very few patients who will be for no treatment at all. So another point I want to bring here, that we are claiming that active surveillance and active intervention have equal result. In my opinion, no. There are data coming up. I don't want to claim much because data are not randomized data, but there are data where we did the watchful waiting or active surveillance, where survival difference was about 2.5%. All we need to tell our patient that there is a chance of a little bit inferior outcome with active intervention versus active surveillance. Radical surgery, I'm not surgeon. Dr. Jamsari is here in the hall. He is surgeon, so I leave for him. I don't recommend, but that's my bias because I'm a radiation oncologist. And then external beam radiation and brachytherapy. So as I said, I would not talk all of the topic, but just talk about few. So active surveillance, I already explained that this is delayed treatment. Radical surgery have to inform the patient that this is with the condition that you may have a chance for radiation salvage and hormone treatment. So it's a package. For about 30 to 40% of the patient would actually require radiation and hormone treatment, and their outcome is not better than surgery, and they have the toxicity of both treatment. As long as your patient know this option and go for radical surgery, perfectly fine. But whenever, in my opinion, in my urologist in Oman at the moment, because we do MDT-based clinic, and in that MDT-based clinic, we offer all option, and my surgeon didn't get any radical prostatectomy in last 2 years. So my apologies to them, they are not here, but Jam can convey to them. But anyway, so this is an important point to know about surgery. Then we come to the external beam. We know that in this group, 78, there are 30 up to 39 fraction, 74 to 78. And then moderate hypofractionation, 60 to 64.6 and 90 to 20 fraction. And now Dr. Binaz have already explained that in the 5 fractions. So most of the people switching to that, and it's a very good treatment, alternative treatment for them. So I'm not talking about them. LDR brachytherapy would be again discussed later on, which we started in Oman. So we started LDR brachytherapy. We are the leader in the region for that. And thanks to Dr. Zahid and Sultan Qaboos to provide all facilities. HDR brachytherapy with a 2-session in 1 week or 2 week apart. I would say this is not a standard as monotherapy at the moment, because there are studies going on, Canadian study PR19, where they are actually assessing, comparing 2 sessions of HDR versus 1 LDR. And when I talked to the principal investigator, she said to me, wait for some time. Results have to come out. It means there is some doubt about 2 sessions of HDR. Anyway, so, and HDR brachy, because HDR brachy nobody will cover, so I just show a couple of slides, like what Professor Pignol also showed some picture. So it's transperineal tube insertion, where we leave the tubes in and then we do plan, and it's ultrasound based mostly, where we give 2 sessions, 1 week or 2 weeks apart. Cryosurgery, you know, it's out of the market a lot, but when I was working in Alberta and Calgary, they were doing cryosurgery and results were claiming to be equivalent to external beam radiation, which you see the picture that, you know, the tubes are inside the prostate, not different from HDR, very similar, but there's another way of cryosurgery. If you live in Alberta, where I come from in Canada, you can just go out in -54. So nitrogen liquid is only -40. And I have faced a temperature of -59. So what do you think? It's easy treatment, isn't it? This guy is, I think, taking the cryosurgery. So high tier or unfavorable intermediate risk. Now here I want your attention. So Dr. Binaz will agree with me that the study phase B trial was for the low tier intermediate risk. I'm talking about high tier intermediate risk. So what options we have? So these patients can have standard radiation. We know that dose escalation study 78 and 39 or moderate hypofractionation, very established, and most of people take moderate hypofractionation. Or LDR brachytherapy as a monotherapy. Excellent outcomes. RTOG 0232 have assessed external beam plus brachy versus only brachytherapy, and they found brachytherapy was enough and there was no need for external treatment. They can also be treated by external beam, hypofractionated moderate, and HDR boost with 1 fraction of HDR boost, which is also very good treatment in my opinion. And if I have facility, I would follow this track, because more and more data coming up that boost as the brachytherapy have better outcome than external beam boost. So I would be more, if my center have all the facility, I would go into this route. Ultra hypofractionated. Now this dose, whether phase B trial should be apply that to the high tier intermediate risk or not. Now in practice, people are doing that. But Dr. Binaz will agree that the study did not include. I want to ask that question, but I see long queue, so I don't want to delay. Already red card for the whole team, so I abstain from that. In my opinion, the current dose of phase B trial is not enough for high tier intermediate risk. Can I show some slides? I thanks to Prof. Pignol who get me these slides. So actually, if you look into the outcome of unfavorable intermediate risk in this study was actually only 79%. And I don't see 79% anymore. Even my high risk study, CHIRP study I'll mention to you, show you later, was about 90% outcome at 5 years. So I think it's too low in my opinion. And I think we should not directly start using the phase B trial to high tier intermediate risk. Agree, Rubenas? She already agreed, so I convinced. So then also, if you look into, there are multiple data where they are saying this dose not enough, then what to do next. So next they are suggesting is to escalate the dose. And can we escalate the dose? What are the issues escalating dose? I learned some other study I did in Canada. You can go to as high as possible, no problem, as long as you save urethra and rectum. This is the main issue. This is PTV, this is prostate, and the PTV is red one. And we give the 5 millimeter margin around and 3 millimeter posterior. And if you can draw the urethra either by K, by gel, or by catheter, you can actually draw PRV and you can protect this area. This can, because tolerance for urethra is up to 42 gray, as far as we know. With this, if you can protect that to 42 gray, rest all, you can escalate the dose. You can go up 45 to 50 gray, which is the suggestion. And there are studies coming up for that. And also be protective to the rectum as well. And this can be done by, if you look at the picture here, exactly the result. And I don't want to waste your time much. High risk category. So in high risk category, we know that again, same dose escalated 78 and 39. Most of the people treat pelvic elective radiotherapy. Is a controversial topic. We will solve it after RTOG study published. Moderate hypofractionation. So here I take the credit because I started the CHIRP study in Canada, where we give 68 grain 25 fraction at the same time to the node 45 and 25. We publish our data, and this study being also taken up by Montreal by Dr. Tamim Niazi, and he presented in last Astro, and our results are actually similar. And because of the shorter treatment time and toxicity almost similar, that we can use 68 grain 25 fraction, and that's what we use in our center. So that saves the time of the patient. So salvage, and because I have to cover a lot of things, so I will just move to now salvage radiotherapy post-surgery. There is nothing new here. We know that we give 46 gray to pelvic lymph node and prostate bed and seminal vesicle bed, and then we boost to the prostate bed alone or seminal vesicle bed, depending on every patient. And we go up to 66 gray and 33 fraction. This is established by the SPORT trial, and the controversy is only whether we give 6 months of hormone treatment or longer hormone treatment if they're high risk. Now, if you look into during surgery capsule is breached, and therefore it was expected that treating pelvic lymph node will be better, and that's what SPORT trial proved. But I was using that the treatment for last 15 years, and I was, thanks to God, that when the result come out, it proved that I'm not wrong, but it was objected as some place. So local failure after radiation. We give external radiation and patient fail only focally, not anywhere else. Biopsy proven. What are you going to do? So the best one I would say, salvage LDR brachytherapy. The reason I'm claiming that because we did RTOG 0526 study, and I got experience to see those patients for long term, and we found the results are 5 year about 70 control rate, and the toxicity was quite tolerable. I have to admit every time I talk about it that first 2 patients of mine suffer more toxicity. Maybe it was my learning phase. We're making hot plan, and the key here is it should not be hot plan. It should be cool plan, because these patients already have radiation. They're actually progressing. They're not recurrent. They're progressing, and what we are doing is supplemental dose. So these patients somehow was not enough sensitive that external beam was enough. So therefore, they need further radiation, and this is supplemental delayed boost, I would call it. Forgive me for all these terms I'm inventing in here, but they are supplemental boost by brachy. And when I learned that I have to create a cool plan for them, there was no toxicity. So this is the best in my opinion, but salvage surgery is an option. We just did last week in our center, salvage surgery for local failure because the patient was not eligible for brachy for a multiple reason. And that's the only prostatectomy my urologist got. Dr. Jam was there, actually, he's in the hall. The other part is salvage HDR brachy is getting famous, and people using focal therapy and also whole gland treatment. And I have a feeling that we will go towards focal treatment rather than general whole gland treatment. Hormone treatment is not enough because that's for a short period of time, and the patient eventually fail. HIFU was also tested. So this was my RTOG 0526 study. I skipped that for the interest of time. You can easily find that in literature. Pelvic node positive and oligometastatic or low burden. So this is very important. The slide for me, actually, this is my learning mostly in Oman, not from Canada. Abscopal effect, Prof. Pignol already mentioned about. So what I was doing, I published a phase 2 study from Canada initially for node positive patient, where it published in American Journal of Clinical Oncology, where after node positive gross disease, I was giving full dose to prostate and full dose to lymph node. And because of the improvement in IMRT and SBRT and also IGRT, that we can deliver that. So I did treat them, and I found their results were very similar to what high-risk prostate cancer. So I started treating them radically. I have no hesitation, and that I published 15 years back. And now the time comes that people start doing solitary meds or oligomeds with radical treatment. But I want to take your attention. So this is, if you look at oligometastatic patient in COMET study, there is a small portion of the patient who live very long. So I don't claim my patient who have more metastatic disease that I'm going to cure you, but I tell them you have better progression-free survival, or you may be one of the long-term survivors. But I did not stop there, so I move on, and we doing in our Sultan Qaboos Center that we are treating patients with low burden metastatic disease. For high burden, I give only focal radiation to the prostate. For low burden, I'm giving them full dose to all sites. And with that, our results, this is retrospective data only for 15 patients, not a big data. We submitted in ISTRO and we maybe accepted, and we can present there. That even low burden, even up to 19 metastases, I treated them all. And their PSA is undetectable, which is very unusual for me. They're on duo hormone. My medical oncologist claim is his job. But I say, if your job, then why PSA undetectable? And the patient who are not eligible for duo hormone, how come they are doing it? So this is a very good, new step we took. And you can see how plan look like. Now I'm too enthusiastic. I may be wrong, but so far it's working very well. And we are planning for another study, which is called CLAP-RT. And we will be opening that randomized trial in our Center for Low Burden, which is almost ready to start. With this, I thank you. And I remind you all that there is a Maestro crash course on LDR brachytherapy on January 18. And we will have regular crash courses for learning for the people. Thank you very much.